repeated miscarriages, birth complications, congenital anomalies, or small birth weight baby or intrauterine fetal death. Sometimes the reason can be a simple blood test called as TORCH. What is this TORCH test? Is there anything to worry about? Can a simple cat exposure, viral infection, or a fever during pregnancy silently affect the baby inside your womb? Or there is anything to worry about? Are most of the females unnecessarily worried? I am Dr. Rajat. I'll tell you in this video everything you want to know about TORCH test. What is this TORCH test? What is this TORCH infection? How does the TORCH infection affect the baby? How to diagnose the TORCH test? What does a TORCH positive test mean? Does TORCH test lead to a miscarriage or a congenital malformation or an intrauterine fetal death? What can we do to prevent this TORCH infection? And most importantly, how to have a healthy baby, healthy pregnancy if you have had a TORCH test in the past. By the end of this video, you will know how to interpret the results of TORCH test, what are the costs of TORCH test, what are the preventative measures and the vaccinations and medicines for this TORCH infection. Hello, I am Dr. Rajat and you have started watching our YouTube channel, The Fertility Gynecologist. Like I've mentioned many times before, pregnancy is a immunocompromised condition. God has given this mechanism because fetus, which is made up of a maternal egg and a paternal sperm, it perceives paternal sperm as a foreign body, and anything which is foreign to our body, it has a tendency to get expelled or body fights against it. Because pregnancy is a allograft, something from outside has come inside the body and body has to continue the pregnancy. The immunity during the pregnancy goes down, and as a result most of the females are vulnerable to various infections, viral infections, bacterial infections, protozoal infections. While most of those infections in females are usually mild, but in many cases they can have severe manifestations, severe complications in the child. TORCH. What is this TORCH? I'll talk about this in a minute. This TORCH is an acronym which was coined by a scientist called as Andre Namias in 1971. These are the group of the intrauterine infections which can be transmitted from mother to the child and thereby causing infection. Where T stands for Toxoplasmosis gondii, O stands for other infection which include hepatitis B and syphilis, R stands for rubella, C stands for cytomegalovirus, and H it stands for herpes. The beauty about these infections is they are clinically almost asymptomatic or very, very mild viral illnesses. You may not even know that you have something, and that is why the diagnosis is very, very difficult. The majority of TORCH infections are mild illness, but the fetal outcomes are serious in most of the cases, especially the untreated cases. And that is why the early diagnosis of a maternal TORCH infection is key. Because if we can diagnose TORCH infection early, maybe we can do an important monitoring. Why we are worried about TORCH infections? What do these TORCH infections cause? In a study of about 200 patients, they found that in about 100 patients or almost 50% of the patients, the pregnancy is almost normal, baby is normal, nothing happens. But in rest 50% of the cases, there may be congenital anomaly, there may be a miscarriage, there may be an intrauterine fetal growth restriction, there may be a worst case scenario, there may be a intrauterine fetal death also. There are increase in chances of NICU admissions. Even the neonatal life is not good in many cases. And there can also be a stillbirth. Stillbirth means, I discussed in my previous videos, that baby dies during the process of delivery. It is an intrauterine transmission of the infection which is dangerous, and as a result when the baby is born, if at all baby is alive, there is no miscarriage, if there is no stillbirth, if there is no intrauterine fetal death, then baby is born with congenital malformations and the neonatal life is problematic. It is the timing of the infections which is important. If the patient is already infected before the pregnancy, then if we know, we can treat the infection. But if patient is infected during pregnancy, earlier the infection, the worse the consequences are. I'll come to every infection in detail. T stands for Toxoplasmosis gondii. It is a protozoal infection, and it is a human being is infected by Toxoplasmosis gondii by water and food contamination, especially unpasteurized meat. This is very, very important. The incubation period is about 5 to 23 days. The primary manifestations are IUGR and low birth weight, but it can also manifest as microcephaly or hydrocephalus. The main point about toxoplasmosis is we treat the maternal infection by a drug called as spiramycin. But this pyramycin does not eradicate the placental and the fetal infection, and the fetal infection is taken care of by pyrimethamine, sulfadiazine, and folinic acid, which treats and eradicates the fetal infection in most of the cases. While diagnosis, I'll come to it later on, we normally do a TORCH panel test which diagnose the IgG and IgM. IgM signifies the acute infection and IgG signifies the chronic infection. That means the mother is immune, but there is a catch. In IgG, there is something latest which has come is an avidity testing. If infection has occurred, IgM will be there after few days, and after 3 weeks, IgG will appear, but the initial IgG which appears has got low avidity and it is not fully mature. So an IgG with low avidity, that means we need to treat this toxoplasmosis in spite of the fact that IgG is there. And if IgG has got a high avidity, it means that IgG is mature and the patient is immune to the infection. So that is why even if IgG is positive, we have to go for a avidity assay. If the avidity assay is suggestive of low avidity, that means patient is still having an acute infection and you need to treat that. If we suspect the fetal infection like ventricomegaly, microcephalus, hydrocephalus, intracranial calcification, then we need to go for an amniocentesis at 21 weeks and we need to diagnose, we need to do a PCR from that fluid for the toxoplasmosis DNA. So that's what we have. One tablet twice daily for 3 weeks, followed by 3 weeks rest. Again, we give one tablet twice daily for 3 weeks, followed by 3 weeks rest. And if on ultrasound we find that all these findings of a fetus are there, then we can treat it. The earlier we diagnose, the better it is for the treatment. What I do in my practice, if a patient of a miscarriage, past history of a miscarriage or past history of a congenital malformation has come, and if we happen to do TORCH test for some reason, if toxoplasmosis IgM comes to be positive, then we start spiramycin at least 3 months before delivery, before pregnancy, and then we stop. Then when the patient conceives, we start spiramycin again and we continue spiramycin throughout the pregnancy, 21 days on and 21 days off. Rubella. While rubella has been eradicated from this earth, but rubella is still transmitted from person to person by droplets. The disease is a very short duration, 1 to 5 days, and it is mostly mild or asymptomatic disease. But once the baby gets rubella, congenital rubella syndrome has got no treatment and it causes miscarriage and intrauterine fetal death in most of the cases. So in an ideal world, every female before pregnancy should get her rubella IgG done and IgM done. Normally we get rubella IgG only. If rubella IgG is absent, that means patient is not immune to rubella. Then in those cases we give rubella vaccine, and after rubella vaccine we ask patient not to conceive for at least 3 to 6 months, minimum 3 months, ideally 6 months. We ask patient not to conceive because where it is a vaccine preventable disease, rubella has almost been eradicated from this earth. Next infection is cytomegalovirus. It is ubiquitous and it is the most common congenital infection. Almost every human being on this earth is having a cytomegalovirus infection. It is spread via general contact or via infected saliva, urine and genital secretions. Almost 50 to 70% of the human beings on this earth are having this because human beings are the reservoir of this infection. Why we do not know? Because we can mount an immunity against this infection, and this infection, while it is not killed, it is not eradicated, it stays in our body. It is reactivated whenever the immunity is low. A normal person like you and me may not have rubella, but pregnant females or immunocompromised female persons, the rubella this cytomegalovirus can easily be reactivated. We do not have a treatment for cytomegalovirus. Some people prefer valacyclovir or ganciclovir, especially in infants who have been affected with CMV. For those females who have got a past history of cytomegalovirus IgG or IgM positive, normally I tend to give immunoglobulin Varglob every 21 days for 3 months before conception. While there are no proven reports whether this immunoglobulin Varglob works or not, but I have found a decent way it helps in my next pregnancy. Next infection is herpes. Herpes is caused by herpes simplex virus. There are two types of virus, herpes simplex virus 1 and herpes simplex virus 2. Herpes simplex virus 2 is a sexually transmitted infection. Herpes simplex virus 1 is a infection which occurs in childhood through the non-sexual contact. Incubation period is about 4 to 21 days long, and in most of the patients the primary genital herpes is asymptomatic or there may be some painful vesicles. The important point to note is this virus is not transmitted intrauterine. It is transmitted during the delivery. Perinatal transmission is there. And if it is treated in pregnancy, it is good. You can give simple acyclovir tablet 800 milligram 3 to 4 times a day for 5 to 7 days, and in most of the cases this virus is eradicated if it is diagnosed in pregnancy earlier. But if fetus is affected by herpes simplex, and if the neonate is affected by the herpes simplex, then that case becomes severe. The baby often goes to the NICU. There are meningoencephalitis and sepsis-like syndrome and everything. And last infection is syphilis. Syphilis in last 3 to 4 decades has almost been eradicated. If patient is having syphilis, it can either lead to an intrauterine fetal death or a hydrops, where there is a swelling in the edema of the baby. While I may not go into the details, we normally test for syphilis in almost all the cases. We test for a VDRL or a rapid plasma reagent RPR test. If this test is positive, then we need to treat the patient as soon as possible. Benzathine penicillin is given in the mother, and if child is diagnosed with the syphilis, even to the child the benzathine penicillin is given. So before coming to the diagnosis, I'll come to the prevention aspect. Like I mentioned, how it spreads. So any people who are sick, who are having viral infection, flu, a female should avoid having contact with those people. If need arises, then you need to wear mask like we used to do it in COVID, because these infections can spread by the secretions. And a proper regular hand hygiene, regular washing of hands with soap and water is recommended. We advise not to share utensils, not to drink or eat each other's food, and to avoid eat fully cooked. That is very, very important. Not eat unpasteurized or uncooked or partially cooked, especially meat, poultry and eggs. Early intervention and early treatment of toxoplasmosis and HSV may avoid the problems in child. If there are symptoms suggestive of TORCH infections and if it is diagnosed early, the perinatologist should be reminded to get the TORCH test done for a child. And safe sexual practices, avoidance of multiple sexual partners and using of a barrier contraceptive is very, very important for prevention of HSV and syphilis. Safe eating practices like avoidance of processed food, thoroughly cooked food, and those females who have had history of toxoplasmosis, they need to avoid the exposure of cats. Vaccination is a very powerful tool with us, especially with varicella zoster and rubella. Any female who is planning a pregnancy must have vaccination done for varicella zoster and rubella, or get checked for the antibodies against them. If IgG is positive, then there is nothing to worry. And most importantly, before planning a pregnancy, get an STI test done. STI means HIV, HPS, VDRL. If it is positive, then start treatment first for that thing and then plan a pregnancy. So how to diagnose the TORCH test? Most of the cases are asymptomatic, or most of the cases are viral asymptomatic or mildly symptomatic flus or fevers. Not for every fever we can do a TORCH test. So only in those cases in which there are history of abortions, multiple abortions, history of stillbirths, past history of fetal growth restrictions, or history of intrauterine fetal death, we do TORCH test either during pregnancy and most likely before planning of the pregnancy. This TORCH panel test consists of IgG and IgM. Like I mentioned, any human body mounts an acute response to an infection. Acute response is manifested by IgM, and then there is, after 6-8 weeks, there is a chronic response, that is IgG. IgM suggests acute infection is there. IgG suggests that there is a immunity to the infection. The levels of these antibodies, if it is less than 0.9, it is non-detectable. 0.9 to 1.1, it is positive, borderline positive, and if it is more than 1.1, it is definitely detectable antibody. So, especially in toxoplasmosis and CMV, with IgG, we do another test called as avidity testing. IgG, if it is positive, we do an avidity testing. If it is of a low avidity, that means the infection is still persistent in the body and we need to treat for the infection. If that IgG is of a high avidity, that means the patient is immune to that particular infection and we do not need to go for a treatment again. So how does it interpretation of a TORCH test? Many doctors, if they find that toxoplasmosis, I'll come to it one by one. Toxoplasmosis, if IgM is positive, patient has got history of infections or history of abortions or history of miscarriages, and patient comes to me before the pregnancy. What I'll do is I'll ask the patient to withhold the pregnancy for 3 months. I'll give the patient spiramycin 1 BD for 21 days, and that I'll repeat it every monthly. And then I'll ask the patient to conceive. Even during pregnancy, I will give the spiramycin 1 tablet twice daily for 3 weeks, then have a 3-week gap. Again, give spiramycin 1 tablet twice daily for 3 weeks, have a 3-week gap till the delivery. If during anomaly scan, 3D, 4D scan, there is an evidence of a fetal infection, then I'll start the female with pyrimethamine, sulfadiazine and folinic acid combination for the eradication of the fetal infection. Rubella. If rubella IgM is positive and patient is having pregnancy, I'll straight away go for a termination of pregnancy because this pregnancy cannot survive. After the termination of pregnancy, I will give the rubella vaccine. Rubella is a live vaccine, and that is why we have to wait for 3 to 6 months after the vaccination to have further pregnancy. Most of the doctors, even if the rubella IgG is positive, they still give the vaccination, which in my humble opinion is not the right way to do. If rubella IgG is positive, that means patient is already immune to the rubella and the patient can safely plan the pregnancy. Or if pregnancy is there, there is nothing to worry. Cytomegalovirus. If IgM is positive, like I mentioned, there is no treatment available, but still we can try ganciclovir or valacyclovir if patient is having symptoms, but most of the human beings have enough immunity to counter that symptoms. IgG, what I have found in my practice, in most of the patients who have got a past history of miscarriage or recurrent miscarriage, IgG is positive. Like I mentioned before, almost every second person on this earth is having CMV, cytomegalovirus infection, and it tends to get reactivated during the times of low immunity or fever. What I do in my practice, even if IgG infection is positive, I give Bharglov injection every 21 days for 3 months before pregnancy, and if patient has come during pregnancy, we can still give Bharglov injection. We give it every monthly for 3 doses. While there are not many studies, trials regarding the use of Bharglov injection during pregnancy, but I still use it and I have found decent results. Herpes simplex virus. Even if IgG is positive, even if IgM is positive, I tend to give acyclovir tablet 800 mg 3 times a day for 5 to 7 days to both the partners. That is very, very important. If patient comes to me before pregnancy. If patient comes to me during pregnancy with symptoms, still I give to only female partner because I normally advise against sexual contact in the pregnancy. And syphilis, like I mentioned, benzathine penicillin after negative test dose has to be given. Disclaimer, please consult your doctor. Please do not take the medicines directly. Please consult your gynecologist or your doctor before taking these medicines. What is the price of TORCH tests? It costs somewhere between 2,000 to 3,000 rupees. Some doctors get only toxoplasmosis IgM done. We call it as a TORCH 5. I do not get toxoplasmosis only IgM done. I get the whole TORCH test done. That means both IgG and IgM. Hope you like the video. Please like the video. Please share the video. Please subscribe to our channel. And if you have any queries or if you want me to make another topic, kindly suggest to me in the comment box. Thank you. Bye-bye. Namaskar.